Let's talk about parathyroid glands now. This is an important topic. A lot of MCQs are being asked from this. Before we discuss about the actual conditions, let's talk about the embryogenesis of parathyroid glands. Now, the embryogenesis of parathyroid glands, you have superior and you have inferior parathyroids. The superior parathyroids develop from the fourth pharyngeal pouch. They develop from the fourth pharyngeal arch. And inferior from the third pharyngeal arch, right? So this is important to know. And one more thing which you need to know, that the inferior parathyroids have a variable location. They have a variable location as compared to superior parathyroids, which pretty much have a constant location. The inferior parathyroids along the third pharyngeal arch also gives rise to the thymus. And the reason why I'm telling you this, when I talk about hyperparathyroidism, there is going to be one of the management options is also to remove the thymus, especially when the inferior parathyroid adenoma is there, right? Not because the thymus is anyway responsible for that hyperparathyroidism, but it has been seen that the yield of the inferior parathyroid increases if thymectomy is also done. So I'll cover that point, but I just wanted to tell you the reason behind that is because they both have similar embryogenesis, and when we have to remove the inferior parathyroid, the yield increases if we remove the thymus along with that. Now, if you remember the anatomy of thyroid gland, I told you the inferior thyroid artery supplies the parathyroid gland. The inferior thyroid artery, this supplies the parathyroid glands. Which is why, if you remember, I told you never ligate the trunk. We never ligate the trunk of inferior thyroid artery because we can devascularize the parathyroid glands, and we only ligate capsular branches. Only ligate capsular branches close to the gland. Close to gland. So this is another surgical anatomy point which you need to remember regarding parathyroid glands. Now, you remember that parathyroid glands help in maintaining the calcium homeostasis of the body. And one more point which I want to highlight here is that I told you that superior parathyroids, you can see here, superior parathyroids are usually located on the posterior surface of the thyroid gland. Posterior surface of the thyroid gland, whereas the inferior parathyroids have a variable location. They have a variable location. And you also need to know that 5% population has 5 parathyroid glands. 5% population has 5 parathyroid glands. Another point which I want to highlight here is that parathyroids are very small. Right? And during surgery, how do we localize the parathyroid? So if you look here, this is the parathyroid. And to identify the parathyroid during surgery, we look at the sentinel pad of fat. We look at the sentinel pad of fat, right? There's going to be a sentinel pad of fat, and the parathyroid changes color. It becomes dusky if stimulated. If you touch the parathyroid, you will see that it suddenly becomes dusky. So it's very sensitive to touch, and it will suddenly become dusky or blackish in color. That is how we identify the parathyroid glands. But what I want to highlight with this diagram is that they are very small, and they can sometimes get, you can confuse them for a lymph node, and you can end up removing them. So a lot of times, inadvertently a lymph node would be removed thinking that it is the parathyroid gland. And as my professor always used to joke, the parathyroid gland, the color of the parathyroid gland is yellowish in color, and he always used to joke that it looks like the tongue of a jaundiced hummingbird. And the reason why he used to say that was that it is difficult to localize them. So first you find a hummingbird, and then you wait for the hummingbird to get jaundice and then to stick out the tongue. So basically what he was trying to teach us was that you really need to be very observant to localize the parathyroid glands. Otherwise, you can end up removing the wrong structure. Now, in parathyroid glands, the first thing which we need to talk about is hyperparathyroidism. This is the most important topic which we need to discuss here. Hyperparathyroidism. Now, hyperparathyroidism can be of multiple types. So we'll discuss the types of hyperparathyroidism, but let's talk about the clinical features first. The clinical features would pretty much remain the same if there is hyperparathyroidism, and these can be remembered with a mnemonic, that is bones, stones, abdominal groans, bones, stones, abdominal groans, and psychiatric overtones. Right? So what are the findings which you can get in bones? In bones, there can be pathological fractures with which patients can present. Pathological fractures. Another finding in bones, there can be subperiosteal bone resorption. So there can be subperiosteal bone resorption. Subperiosteal bone resorption can be there. And you need to know that this subperiosteal bone resorption is commonly seen in the digits, and that too the second and the third digits. And it is more common in the radial aspect of the fingers. More common in the radial aspect of the fingers. So more common in the radial aspect of the fingers, and you can see the image here. Look at the image, and you can see that this subperiosteal bone resorption, there's some scalloping of the bone along the radial aspect of the fingers. That is what you see in this image. So you should remember this for the exam. Another thing which you can get is you can get a salt and pepper skull. You can get a salt and pepper skull on X-ray. This is what salt and pepper skull looks like because of bone deposition and resorption. This is what you get, salt and pepper skull. And in advanced cases, you can also get osteitis fibrosa cystica. Osteitis fibrosa cystica. Osteitis fibrosa cystica, you can see here, these are the cystic spaces which can develop in advanced cases. This is osteitis fibrosa cystica, also known as von Reckling-Hossen's disease of the bone. You know, von Reckling-Hossen's disease is otherwise neurofibromatosis 1, but this is von Reckling-Hossen's disease of the bone, which is seen in advanced cases. And another thing which you can get is proximal myopathy. Proximal myopathy can also be seen in these patients. Now, these patients can get recurrent and multiple stones, recurrent, multiple renal stones can be there. And these are actually this is the most common presentation of hyperparathyroidism. The most common symptomatic presentation is in the form of multiple and recurrent renal stones. There can also be nephrocalcinosis. Why do these patients have abdominal groans? They can have colicky pain in the abdomen, or they can develop pancreatitis. If you remember the pancreatitis module, I've told you one of the causes of acute pancreatitis is hyperparathyroidism. And these patients can also get psychiatric symptoms because the raised calcium and the raised PTH, that depresses the CNS, central nervous system. One of the pathognomic features of hyperparathyroidism is band keratopathy. Band keratopathy is deposition of calcium phosphate crystals. Deposition of calcium phosphate crystals in the cornea. But because these days the diagnosis is done early, that is why this sign is also being seen less commonly. But if it is present, it is a pathognomic feature of hyperparathyroidism. So these are the clinical features which you need to know in hyperparathyroidism, and they will remain pretty much constant in various cases of hyperparathyroidism or causes of hyperparathyroidism. Now let's first talk about primary hyperparathyroidism. So first is primary hyperparathyroidism. Now, primary hyperparathyroidism can either occur due to an adenoma, that is a single gland enlargement, or hyperplasia, when there is multiple, all the glands are enlarged, or it can also be seen in parathyroid cancer. Right, so we'll talk about these things in detail, but when there is hyperparathyroidism due to these causes, what is going to happen? That there is going to be increased PTH. There will be increased PTH values. And you know this increased PTH value is going to get calcium out of the bone and into circulation. Calcium out of the bone and into the circulation. So this is going to give rise to hypercalcemia. Hypercalcemia is going to be there. Increased serum calcium will be there in these patients. Right? In addition to this, this PTH will cause increased urinary excretion. There is going to be increased urinary excretion of calcium and phosphate both. So urinary calcium and urinary phosphate will both be increased. But this is going to give rise to decreased serum phosphate, whereas the serum calcium levels don't decrease because more and more calcium is coming out. So serum calcium levels won't decrease, but serum phosphate levels decrease. So these are the biochemical changes which are seen in primary hyperparathyroidism. You have raised PTH, you have hypercalcemia, increased urinary and calcium and urinary phosphate, and decreased serum phosphate values. Clinical features we have already discussed: bone stones, abdominal groans, and psychiatric overtones. Right? Patients can also have features of hypercalcemia. There can also be features of hypercalcemia. There can be features of hypercalcemia which can include confusion. There can be confusion, there can be vomiting in these patients, and these patients can also have ECG changes. They can also have ECG changes. You know the ECG changes which are seen in hypercalcemia are increased PR interval, and shortened QT interval, and a shortened QT interval. So patient can even present with these features, and a subgroup of patients can be asymptomatic as well. They can be asymptomatic in primary hyperparathyroidism as well. You know that these days a lot of patients are opting for preventive health checkups, and a lot of these parathyroid adenomas are picked up in patients who are asymptomatic, and when they get their preventive health checkups done, the calcium levels are found to be high, and when you investigate further, that's when you pick up these problems. So these are the clinical features. Now I told you the two main causes of primary hyperparathyroidism. You can either have an adenoma, or there can be a hyperplasia. Now adenoma is when one gland is enlarged and rest of the glands are normal, and hyperplasia is when all four glands are enlarged. Okay. You need to know that adenomas are much more common than hyperplasia. The only condition where hyperplasia is more common is MEN1 syndrome. In MEN1 syndrome, hyperplasia can be more commonly seen, but otherwise adenomas are more common than hyperplasia. So adenoma is a single gland enlargement. Hyperplasia is when all four glands are enlarged. So you should also know that the risk factors for primary hyperparathyroidism, the risk factors are radiation exposure. Radiation exposure can give rise to either of these things, and they can be seen in syndromes like MEN1 and MEN2A, and 5% patients in these syndromes can have multiglandular disease. There can be multiglandular disease which can be present in these patients. Now, as we've discussed the clinical features, we've discussed the biochemical features. Now, I need to know whether the patient has an adenoma or hyperplasia. Just by the clinical features and by the biochemical features, I can't get to know that. So, I need some form of imaging to guide me to whether it's an adenoma or hyperplasia. And the most sensitive imaging test for parathyroid glands and the most sensitive imaging test to localize parathyroid tissue, this has been asked multiple times, is a sesame B scan. So this is a nuclear medicine scan. It is a technetium-99 sesame B scan. And this sesame B, this compound sesame B, is going to localize to mitochondria. It is going to localize to mitochondria, and because parathyroid is rich in mitochondria, that is why they shine on this sesame B scan. So you can see here on a sesame B scan, when the sesame B scan is done, you can localize a parathyroid adenoma because it is going to localize to mitochondria. But you can get a false positive. You can get a false positive in patients with Warthin's tumor. You can get a false positive in patients with Warthin's tumor. You can see that here also it is shining because Warthin's tumor is also rich in mitochondria. Okay, so please remember this point. Another imaging test which is used for parathyroids is SPECT. SPECT is single photon. It is single photon emission computed tomography, CT. So single photon emission CT is also an imaging test for parathyroids, but the most sensitive is sesame B scan. So when I do the sesame B scan, I will get to know whether the patient has an adenoma or whether the patient has a hyperplasia, right? And that is what is going to govern the management for me as well. So if I talk about the management of primary hyperparathyroidism, you have to manage the hypercalcemia. So if the patient is coming with hypercalcemia, the management of hypercalcemia is going to be IV fluids. First, we give IV fluids. Then we can give the patient furosemide or IV diuretics can be given in these patients. And these patients, once the KFT normalizes, once kidney function test is normal, we can give IV bisphosphonates. IV bisphosphonates can be given, and we usually give IV zoledronic acid in these patients. Right? So that is how we manage the hypercalcemia, whether it is an adenoma or it is a hyperplasia. Now the definitive management of this condition is going to be surgery, and the surgery for adenoma and hyperplasia is quite different. So the surgery, if we talk about, if you have a patient with an adenoma versus a patient with hyperplasia, surgery for adenoma is removal of the adenomatous gland. Right? That is the surgery for an adenoma. Now, this might sound very easy, but trust me, it isn't. So let me just tell you a clinical scenario which has happened quite a number of times, which is why a lot of modifications have come up to ensure that the right gland is being removed. So there is a patient who comes to a surgeon with a parathyroid adenoma. The surgeon is pretty excited because it's not every day that you get to operate on a parathyroid adenoma. You are the intern. He takes you along in that surgery. You are also excited. You open up the neck and you remove one of the parathyroid glands. The patient goes home, is discharged comfortably, no problem at all. But what happens is that the patient comes back after a month or so and says, look, my symptoms have not subsided. My symptoms are increasing. You do the PTH values, the PTH is high. You do calcium, calcium is high. Now the patient is very angry and you are confused. You do a sesame B scan and you see that the adenomatous gland is still there. And I've told you that because the glands are so small, you can sometimes miss it. You can remove a lymph node rather than the parathyroid gland. So now the patient is very angry and he asks you, what should I do? So you tell him that I will follow a new technique and make sure I remove your parathyroid gland, which is the enlarged gland. So what is that new technique which we follow? It is given in the latest Bailey as well. This is known as the Miami protocol. So whenever you're doing surgery for a parathyroid adenoma, we should follow the Miami protocol. What exactly is the Miami protocol? Miami protocol is that we measure the pre-operative PTH value. We measure the pre-operative PTH value and we measure PTH within 15 to 20 minutes of gland removal. We measure PTH within 15 to 20 minutes of gland removal. The key here is that the half-life of PTH is 7 minutes. And I can never forget this because this was my thesis when I was a postgraduate. So my thesis was to predict which patients are going to develop hypocalcemia after thyroidectomy by doing intraoperative PTH values. So in those patients where the PTH value was dipping intraoperatively, that means we have inadvertently removed the parathyroid glands, and those were the ones which were likely to develop hypocalcemia. Okay. So we use the same principle here. We measure the preoperative PTH value and we measure PTH within 15 to 20 minutes of gland removal. If there is a more than 50% drop in PTH value, that means the right gland has been removed. That means we've removed the correct gland or the adenomatous gland, and this is the Miami protocol. You need to remember this. This has been asked in the AIMS exam and this is given in the latest Bailey as well. This is how we confirm that the right gland is removed. Now, another thing which you need to remember when you're doing adenoma surgery is that minimally invasive parathyroid surgery can be done. Minimally invasive parathyroid surgery can be done. And if you remember your module on thyroid, I told you that this minimally invasive thyroid or parathyroid surgery is done most commonly via the transaxillary route. Transaxillary route, we insert laparoscopic ports in the axillary region. We dissect our way up to the neck and then we can do this parathyroid surgery. But this is to be contraindicated or avoided if there is, this is to be contraindicated or avoided if there is a multi-gland disease, if it is associated with familial syndromes, if it is associated with familial syndromes, if it is a multi-gland disease, or if it is lithium-induced hyperparathyroidism, then minimally invasive surgery should not be carried out. Also, what is the role of thymectomy? I mentioned when I was covering the anatomy that sometimes we remove the thymus also in parathyroid hyperplasia. So the role of thymectomy is only in those patients where the inferior parathyroids are implicated, because I told you that they share the same embryology, and if you remove the thymus, you increase the yield of inferior parathyroid. The chance of getting inferior parathyroid would be higher when the inferior parathyroids are involved in secondary hyperparathyroidism and in patients with familial syndromes. In secondary hyperparathyroidism and in patients with familial syndromes, that is where we do a thymectomy, and thymectomy increases the yield of parathyroid tissue. That means the chances of getting parathyroid tissue will be higher during surgery. So this is the management of primary hyperparathyroidism due to an adenoma, and I've told you the indications where minimally invasive parathyroid surgery can be done and the role of thymectomy. What we are left with is a patient who has primary hyperparathyroidism and hyperplasia. You know, in hyperplasia, all 4 glands are involved. 4 glands are enlarged. So there are 2 surgical options here. The 2 surgical options are remove 3.5 glands and leave half gland at same place. This is option number 1. Or option number 2 is to remove all 4 glands and auto-transplant parathyroid tissue. Right? So whenever we are doing surgery for hyperplasia, it is this one which is followed more commonly, where all 4 glands are removed and we take half a gland, we chop it up into small pieces, we put it in cold saline, we take it in a syringe and we auto-transplant this tissue. We auto-transplant this tissue in the brachioradialis, and this has been asked in the exam. We auto-transplant this tissue in the brachioradialis of non-dominant hand. Right, so when we are dealing with parathyroid hyperplasia, we are going to auto-transplant this tissue in the brachioradialis of the non-dominant hand. It can also be done in the sternocleidomastoid, but we usually do it in the sternocleidomastoid if parathyroid is removed by mistake during thyroidectomy. If it is removed by mistake during thyroidectomy, that is when we do it in the sternocleidomastoid. Now you might ask that why are we auto-transplanting this tissue in the brachioradialis? Why not just leave it in the same position? Well, the reason for that is that supposing there is a recurrence, that recurrence would be in the neck. And if you've already operated the neck is already fibrosed. And to find out that small gland in a fibrosed neck is going to be very difficult. Whereas if I put it in the brachioradialis, I'm going to mark it with a suture so I know what is the site where I've kept it. So just in case there is a recurrence, I can easily remove it under local anesthesia. So that's the reason why we put it in the brachioradialis of the non-dominant hand. Now, there are 2 terms which you need to understand here. One term is residual hyperparathyroidism. One term is residual hyperparathyroidism. And the other term is recurrent hyperparathyroidism. Both these terms have been mentioned in Bailey. You should know about them. So you have residual hyperparathyroidism or recurrent hyperparathyroidism. Residual hyperparathyroidism is when increased PTH is seen within 6 weeks. Is seen within 6 weeks of surgery. That is, if it is seen within 6 weeks of surgery, that is residual hyperparathyroidism. And this basically indicates that tissue has been left behind. Tissue has been left behind. Okay. And we've already discussed that if tissue is left behind, you again have to localize it and you have to remove it, and we follow the Miami protocol. Okay. Recurrent hyperparathyroidism is when PTH normalizes, but increases again after 6 weeks. When PTH normalizes but increases again after 6 months or so, that is recurrent hyperparathyroidism. And recurrent hyperparathyroidism is due to a recurrence. Now, this recurrence can occur either in the neck or in the auto-transplanted tissue. Or in the auto-transplanted tissue in the brachioradialis. So we need to determine whether the recurrence has occurred in the neck or it has occurred in the auto-transplanted tissue. And another thing which is written in the latest Bailey, to differentiate the two, we do a Casanova test. So Casanova test is what helps us in differentiating whether the recurrence is in the neck or in the auto-transplanted tissue. And Casanova test is we do PTH measurement. from the neck vein, right? From the neck vein. So you can do it from the inferior thyroid veins, which is where it is going to drain to, and you will do PTH measurement, and you will do PTH measurement in the brachial vessels, right? And a positive Casanova test, is if there is a 20 times higher concentration, if there is a 20 times higher concentration in the brachial vessels. That is a positive Casanova test, and that tells us that the recurrence is in the autotransplanted tissue. And I've already told you, we mark the autotransplanted tissue with either a suture or a clip, and we can easily remove it even under local anesthesia. So this is the entire management of primary hyperparathyroidism. I've told you the management of an adenoma and hyperplasia. This autotransplantation is a very important concept, asked multiple times. Miami protocol is very important, and this Casanova test has not been asked till now, but can be asked in the future. One more term which I want you to know is hungry bone syndrome. And hungry bone syndrome can occur after parathyroid removal, for an adenoma or hyperplasia. And what occurs in this is that the bones actively take in calcium, actively absorb calcium. So when parathyroid was raised, calcium was being leached out of the bones. And now when the stimulus has gone, the bones are going to take up or eat up the calcium. And immediately after surgery, patient can land up with hypocalcemia after surgery. So this needs to be monitored. Once you've done a parathyroid gland surgery, you need to monitor for hungry bone syndrome and treat it accordingly. Now, as I told you, a lot of patients are being detected with asymptomatic primary hyperparathyroidism because of preventive health checkups. Now, which are the patients who require surgery? So, this is the table for indications of surgery. Indications of surgery in asymptomatic primary hyperparathyroidism. In asymptomatic primary hyperparathyroidism, the indications are if the age is less than 50 years of age, if serum calcium is more than 1 milligram per deciliter of the upper value, if the bone mineral density is reduced, if the T-score is less than minus 2.5, or there is vertebral fracture on imaging, if the creatinine clearance is reduced to less than 60 ml per minute, or if the 24-hour urine calcium excretion is more than 400 milligrams per day. Now, I know Dr. Rakesh has said that urine calcium is not an indication, but in Bailey it is clearly written, which is why I'm stating that if the urine calcium excretion is more than 400 milligrams per day, that is also an indication. Or if you see nephrolithiasis or nephrocalcinosis on imaging. So these are the indications to carry out surgery in asymptomatic primary hyperparathyroidism. So the next condition we need to talk about is secondary hyperparathyroidism. And secondary hyperparathyroidism, the causes of secondary hyperparathyroidism are chronic renal failure, or defective intestinal absorption, or malabsorption if there is there, lithium intake, and vitamin D3 deficiency. These are the causes of secondary hyperparathyroidism. Let's just take the example of chronic renal failure. You know, in chronic renal failure, hydroxylation of vitamin D does not occur, and this is going to give rise to decrease in vitamin D3. And if there is decrease in vitamin D3, there is decreased serum calcium because of defective absorption from the intestine. Because of defective absorption from the gut, right? And when there is decreased serum calcium, decreased serum calcium, this is a potent stimulus for parathyroid hyperplasia. For parathyroid hyperplasia. So in secondary hyperparathyroidism, there is going to be hyperplasia of all glands. All glands would be increased in size. And in secondary hyperparathyroidism, what is going to happen? That there will be increased PTH due to this hyperplasia. But unlike primary hyperparathyroidism, there is decreased serum calcium. There is decreased serum calcium, increased serum phosphate in these patients. So this you need to know, there is decreased serum calcium and increased serum phosphate in these patients. So the management of this condition primarily focuses on correction of CRF. Correction of CRF, because if the chronic renal failure is corrected, this is a reversible condition. Everything is going to fall into place. In addition to this, calcium correction, there's going to be vitamin D3 supplementation. Vitamin D3 supplementation is to be done in these patients. These patients need to be given a low phosphate diet. Low phosphate diet needs to be given, and the drug which has revolutionized the treatment of secondary hyperparathyroidism is cinacalcet. Cinacalcet, acts on the calcium sensing. So this acts on the calcium sensing receptors. Acts on the calcium sensing receptors of parathyroid. And this is the one which is going to reduce the parathyroid levels. This is revolutionize the treatment, and surgery is only done if medical management fails. If medical management fails, then we will carry out surgery in these patients. Another thing which you need to know, that if the CRF is not getting managed, then another option is to do a renal transplant in these patients. You should know that secondary hyperparathyroidism can be associated with fibroblast. Fibroblast growth factor 23. So this is the management of secondary hyperparathyroidism. Moving on to tertiary hyperparathyroidism. So tertiary hyperparathyroidism is seen in long-standing chronic renal failure. This is seen in long-standing CRF. We already know that in CRF there is already hyperplasia which is there, right? So hyperplasia is already there. But if it is long-standing chronic renal failure, then one of the glands becomes autonomous or undergoes adenomatous change. So one of the glands is going to enlarge and going to undergo adenomatous change. Now the significance of knowing this is that even if I correct the CRF, also, this is no longer a reversible condition because the gland has undergone adenomatous change. It is no longer a simple hyperplasia. This can also be seen post-renal transplant. So these patients are going to have increased PTH and they will have increased serum calcium. And the management of these patients is surgical removal of the gland and you have to correct the CRF. And we have to correct the chronic renal failure, that is tertiary hyperparathyroidism. So I've discussed primary hyperparathyroidism, secondary hyperparathyroidism, tertiary hyperparathyroidism. Now, before I talk about another term, that is pseudo hyperparathyroidism, there is one more condition which I want to discuss, that is calciphylaxis. That is calciphylaxis. Calciphylaxis, the other term is hypercalcemic uremic arteriopathy. Hypercalcemic uremic arteriopathy is known as calciphylaxis, and in this what happens, this is usually seen in patients with secondary or tertiary hyperparathyroidism, and because of the increased PTH, what happens that there is deposition of calcium. There's deposition of calcium crystals in the skin, in the blood vessel, and subcutaneous tissue. In the skin, blood vessels, and subcutaneous tissue. So what you can get is you can get painful skin nodules. There can be painful skin nodules which can be seen. There can be gangrene which can be seen in these patients. Right, so you can get gangrene also in these patients. That is what you get. And the management of these patients is urgent parathyroidectomy. Urgent parathyroidectomy has to be done in these patients with calciphylaxis, but sometimes you are unable to reverse the gangrene which develops in these patients. Now, the other term which I want to discuss is pseudo hyperparathyroidism. Now, pseudo hyperparathyroidism is also known as hypercalcemia of malignancy. And it is a paraneoplastic condition. You know, paraneoplastic syndromes are those syndromes which cannot be explained by the direct spread or by metastasis, right? They are usually due to some compounds which are released, and the compound release here is PTH-related peptide. PTH-related peptide which manifests these features. This is in fact the most common paraneoplastic syndrome. It is the most common paraneoplastic syndrome, and the most common cancer which gives rise to this is squamous cell carcinoma of the lungs. The most common cancer which gives rise to this is squamous cell carcinoma of the lungs. Mind you, I know that most of the paraneoplastic syndromes are with small cell lung cancer, but this particular paraneoplastic condition is more with squamous cell carcinoma of the lungs. And the clinical features, patients are going to come with hypercalcemia. I've already told you the clinical features. Patient can have vomiting, nausea, confusion. There can be ECG changes. And the management of these patients, IV fluids. This is the first thing which is to be done. First intervention, you hydrate these patients. This has been asked multiple times in the exam as well. IV fluids are to be given. Then you give IV diuretics, furosemide. When KFT returns to normal, when KFT is normal, we give IV bisphosphonates. And we usually use IV zoledronic acid in these patients. So I get a lot of breast cancer patients like this. Some metastatic breast cancer with metastasis to the bones would present with hypercalcemia, and that is how we manage these patients, and then we start the particular treatment for that cancer. So this is regarding pseudo hyperparathyroidism. The next thing which we need to talk about is parathyroid cancer. Parathyroid cancer is also a rare cause of hyperparathyroidism. It is a rare cause of hyperparathyroidism. It is seen in 1% cases. So the risk factors for parathyroid carcinoma are radiation exposure, and hyperparathyroidism, jaw tumor syndrome. And hyperparathyroidism, jaw tumor syndrome. This is due to inactivation of parafibromin. This is due to inactivation of HPRT2 gene or parafibromin inactivation, right? So these are the risk factors for parathyroid cancer. It has an equal male to female incidence, and the clinical features are going to be features of hypercalcemia, which I've already covered. Features of hypercalcemia are going to be there. In fact, hypercalcemia is the most common cause of death in patients with parathyroid cancers. It can give rise to ECG changes, arrhythmias, and that is the most common cause of death in these patients. Biochemically, these patients are going to have very high values of PTH, and the spread of this tumor can either be direct extension, it can be lymph node involvement, or there can be distant metastasis, which can be seen in these patients as well. On histopathology, you are going to see fibrous bands. Fibrous bands are seen, and vascular invasion is also seen in these patients. The management of these patients. One more thing which you need to know, this has been given in the latest Bailey. On histopathology, on immunohistochemistry, you can also get inactivation of parafibromin. Can be seen. And these are PGP 9.5 positive on immunohistochemistry. PGP 9.5 positive on immunohistochemistry. The management of these patients is to get an R0 resection. Surgery is the mainstay of treatment. You try to resect as much as you can. You manage the hypercalcemia, which I've already highlighted twice. How do we manage hypercalcemia? Chemotherapy can be given in these patients. Chemotherapeutic agents are, we can use octreotide as chemotherapy, or azothymidine. Azothymidine can be used in these patients. Cinacalcet can also be used. Cinacalcet is only used in patients with recurrent hypercalcemia even after surgery. If there is recurrent hypercalcemia, then we can use cinacalcet. And cinacalcet, I've already told you, acts on the calcium sensing receptors on parathyroids. So this is regarding all the causes of hyperparathyroidism. Just a few words regarding hypoparathyroidism as well. Now, hypoparathyroidism, in the thyroid module, I've already told you the most common cause of hypoparathyroidism is iatrogenic, when the parathyroid glands are injured or removed during thyroid surgery. And we've discussed the management of hypocalcemia and the clinical signs in that module in thyroid. And another cause from which question has been asked is de Gorges syndrome. Now, de Gorges syndrome is also known as, the mnemonic to remember this is catch-22. This occurs due to deletion of 22q11, that is the genetic basis of the syndrome. And the mnemonic I've told you is catch, that is how you remember the clinical features of the syndrome. C stands for cardiac defects. Cardiac defects can be seen in these patients. These patients can have abnormal facies. There can be abnormal facies which can be seen. There can be thymic hypoplasia in these patients. which can be associated with parathyroid hypoplasia as well, or hypoparathyroidism. Then these patients can have cleft lip and cleft palate, and these patients can have hypocalcemia due to hypoparathyroidism. So that is catch-22 or Degauchi syndrome, and that covers up hypoparathyroidism as well. That brings us to the end of this module. Just a few MCQs which we need to discuss here. So intraoperative PTH assays provide guidance that all hyperfunctioning glands have been removed during parathyroidectomy. What is the criteria which we take into account? I've already told you, more than 50% fall in PTH within 15 minutes of removal. You should remember the name. This is known as the Miami protocol, and it has been asked in the exam as well. A metastatic breast cancer patient presents to the emergency in a state of confusion. She has had multiple bouts of vomiting. Her calcium is 16, so she is come with hypercalcemia. What is the next best step in the management? I've told you the first step is saline hydration. Then we give furosemide or diuretics. Once the KFT normalizes, that's when we start bisphosphonates. For the final years, you should just know about primary hyperparathyroidism. That can be asked as a short note in your college exams. Otherwise, this module is primarily important from the point of view of MCQs. If you have any doubts regarding this module, you can ask me those doubts on the Marrowlinks Facebook group. This is a group where specifically you can ask your queries, or you can message me on my Instagram handle, that is left-handed surgeon. Thank you.